The Honorable, our outstanding speaker, Professor Babatunde O. Bambose, DDS, MS, MD, FMCDS, FWACS, certified in oral and maxillofacial radiology. And the Honorable to all the participants who joined this international lecture. Ladies and gentlemen, on this special occasion, I would like to introduce myself. My name is Rizcha Alvina, as Master of Ceremony, and proud to present the outstanding speaker from Nigeria, Professor Babatunde. The topic of today's webinar is about deep understanding of panoramic interpretation. Today's event is a hybrid meeting, which is held by online and offline. There are around 300 participants have registered in this webinar. Before we are going to the main session, let's raise for Indonesian anthem and Hasanuddin University March. Para hadirin disilahkan berdiri.
Hasanuddin, panjimu kita bawa serta, panjangkan di medan bakti, namamu kita bawa bersama, membina kejayaan Nusa, Indonesia bahagia, putra putrimu kini bangkit dengan jiwa Hasanuddin. Gerakan kami padamu negeri, izinkan kami bagimu pertiwi, alma mater Universitas Hasanuddin.
Please be seated. Hadirin dipersilakan duduk kembali. Ladies and gentlemen, let me deliver the agenda of the event today. There will be opening, which we are now in the opening session. The second is the speech from head of oral and maxillofacial radiology specialist program, Dentistry Faculty of Hasanuddin University. The next is the speech from the Dean of Dentistry Faculty of Hasanuddin University and officially open this webinar. The next is the main lecture, which will be delivered by Professor Babatunde, and the last is closing. Next, I would like to welcome to the head of oral and maxillofacial radiology specialist program to deliver her speech. To the Honorable Prof. Barunawati, time is yours.
Thank you very much, Dr. Rizka, to speak to me. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Vice Rector for Academics and Students Affairs, Professor Muhammad Ruslin, DDS, Master and Health Science, PhD, Specialist and Consultant in Oral and Maxillofacial Surgery. The Honorable Dean of Faculty of Dentistry, Hasanuddin University, Professor Dr. Edi Mahmud, DDS, Specialist and Consultant in Prosthodontic. The Honorable Chairman and Secretary of Senate of Faculty of Dentistry, Hasanuddin University. The Honorable Head and Secretary of Quality Assurance Division of Faculty of Dentistry, Hasanuddin University. The Honorable Head and Secretary of Departments is Faculty of Dentistry, Hasanuddin University. The Honorable Head of Study Program in Faculty of Dentistry, Hasanuddin University. The Honorable Chairman of RKG, Association of Dentomaxillar Facial Radiology in Indonesia, the Honorable Chairman and Secretary of College of Dentomaxillofacial Radiology in Indonesia, the Honorable Head of Oral and Maxillofacial Radiology Specialist Program for Universities Pajajaran, Universitas Indonesia, and Universitas Airlangga. The Honorable, our outstanding speaker, Professor Babatunde O. Bangbose, BDS, DDS, MS, MD, FMCDS, PWIGS, certified in oral and maxillofacial radiology. And the last, Honorable, all the participants and invites who joined the international lecture. I respect all of the participants who have attended this hybrid lecture by online and offline here, especially to organizer of this event international guest lecture, which I am proud. First of all, let us say prayer to Allah Subhanahu wa Ta'ala, who gives thousands of effort to us until this day we can implement this hybrid webinar with full of strong sense of community and say gratitude to Allah as Lord who gave us healthy and wealthy. The preface, I am a head of oral and maxillofacial radiology specialist program, will say thanks to all parties involved who have spared their time to help this hybrid webinar event. Thanks to all the community who give the best effort until this event can be successful and have given to me and time to give a speech and officially open this hybrid by webinar. This hybrid lecture is the mandatory event of oral and maxillofacial radiology special program in dentistry faculty Hasanuddin University. The offline participants are 50 attendants, and in online platform are 300 participants, and total our participant is 350. Please enjoy the webinar. Hope I will give a new insight to all of us, give improving the quality and human resources for better service of oral and maxillofacial radiology. We apologize if we, as the organizer, especially from me, say sorry for the perfection and imperfection is this webinar hybrid. Before I close this speech, I wish this webinar hybrid always to be success and blessed by Allah Subhanahu wa Ta'ala. Thank you. Thank you very much for your attention. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for the speech, Prof. Moving to the next agenda is opening speech from the Dean of Dentistry Faculty of Hasanuddin University to the Honorable Prof. Edi. Time is yours.
Yeah, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. The Honorable, the Vice Rector Academic and Student Affairs, Professor Muhammad Ruslin, and all of you participants. Good afternoon to the audience in Indonesia, and good morning to Professor Babatunde in Nigeria, because there is indeed a time difference between Indonesia and Nigeria. First of all, I would like to thank you to the Professor Dr. Barunawati Yunus, Dr. Gigi, SP RKG consultant, as a head of the Dental Radiology Specialist Study Program, Faculty of Dentistry, Hasanuddin University. And then Dr. Gigi Irfan Sugianto, Master Medical Education, PhD, as a chair of the Department of Dental Radiology, and also as a Vice Dean for Academic and Student Affairs. Is your best friend when taking a doctoral education program in Japan, and a few years ago, Prof. Babatunde. I know you from him. And furthermore, Dr. Gigi Mulyati Yunus as Secretary of the Dental Radiology Department and a resident of PPDGS Dental Radiology, who have worked well to present a guest lecture today. And especially for Professor Babatunde, I express my high appreciation for his time and sharing of knowledge in the field of dental radiology. Hopefully, it will be useful for the world of humanity. And hopefully, the relationship can continue between Bayero University, Nigeria, and Hasanuddin University, Indonesia. As the Dean of the Faculty of Dentistry, Hasanuddin University, I would like to express my highest gratitude to Professor Babatunde, and let us officially open this event. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
To guide prayers. Dr. Rahmat, time is yours.
Thank you from NC. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Professor Babatunde Bambose. And good afternoon, our professor, our lecture at RKG, and in public lecture today. Before we start a public lecture, let us bow our hearts and heads for a moment while praying to Allah Subhanahu wa Ta'ala. Bismillahirrahmanirrahim. Hamdan yu'afi ni'amahu wa yukafi mazida. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhika wa azimi sultanik. Allahumma salli ala Muhammad wa ala alihi wa ashabi ajma'in. Bismillahillazi la yadru ma'ashimi syai'un fil ardh wa la fis sama' wa huwa as-sami'ul alim. Allahumma la sahla illa ma ja'altahu sahla wa anta taj'alu hasna idza syi'ta sahla. Ya Allah, ya Fattah, ya Razzaq. We gather here to carry out a public lecture, Deep Understanding of Panoramic Interpretation, together with Prof. Babatunde Bambose. We ask you to allow and bless our activity in the light of your guidance. Make it easy and smooth for us to carry out all these activities. Ya Allah, Ya Fattah, Ya Alim, you are the one who hold our destiny and open the doors of our hearts and minds so that we can receive all the knowledge that will be conveyed in today's public lecture. Ya Allah, Ya Qawi, Ya Aziz, please give us your strength physically and spiritually so that we are prepared and able to implement the knowledge we have received from our lecture. Ya Allah, Ya Ghaffar, Ya Qahar, forgive all our sin and mistake, our parents, our lecture, and accept our prayers. Rabbana atina fid dunya hasana wa fil akhirati hasana wa qina azabannar. Amin. Amin. Allahumma ya rabbal alamin. Thanks very much for attention. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Doc. Ladies and gentlemen, we are going to the main agenda. Who will be in charge is Dr. Gigi Fadil Ulum as a moderator. But before that, let me read his CV shortly. He was born in Ujung Pandang, 30 December 1987. He is staff and lecturer of the Oral and Maxillofacial Radiology Department of Dentistry Faculty of Hasanuddin University and certified in Oral and Maxillofacial Radiologist. That's all the CV. Now I would like to hand over the session to him. Please, Doc, time is yours.
Okay, thank you very much for Dr. Rizka for your praise. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning for Professor Babatunde in Nigeria and good afternoon for all of the participants in Indonesia. The Honorable, our outstanding speaker, Professor Babatunde Olamide Bambose. Okay, I have to read your very long name, Professor. Professor Babatunde Olamide Bambose, BDS, DDS, MS, MD, FMCDS, FWACS, and also Professor Babatunde is certified in Oral and Maxillofacial Radiology in Nigeria, and also he is a professor in Oral and Maxillofacial Radiology for Oral Diagnostic Science Department in Faculty of Dentistry, Bayero University, Kano, Nigeria. Hello, Prof. How are you? Can you hear my voice clearly, Professor?
Yes, I can hear you. Thank you.
Okay, how's life there, Professor?
Life is good. Thank you.
Okay,
It's good to be here.
Alhamdulillah. Yeah, we hope everything is fine, Professor. Okay, the honorable all of the participants, especially for our head of oral and maxillofacial radiology specialist program for Faculty of Dentistry of Hasanuddin University, Professor Dr. Gigi Barunawati, and our dean, Professor Dr. Edi Mahmud, specialist and consultant in prosthodontics. And also for your information, Professor Babatunde, in the participants, we have our chairman of Indonesian College of Dentomaxillofacial Radiology. We have Professor Hana here. Good afternoon, Professor Hana, and also our chairman from Indonesian Association of Dentomaxillofacial Radiology in Indonesia. Well, we say it, IKARGI, like American Oral and Maxillofacial Radiology in the other region.
That's good.
Okay. I would like to say thank you very much for Professor Babatunde because for your time, for spare your time with us, for deliver your presentation for our international guest lecture. And I think in your busy day as a professor and also as a dean, correct me if I'm wrong, Professor, in in Faculty of Dentistry of Bayer University, but you still can accepting our invitation to be a speaker in our international guest lecture. And for all the participants, I will be responsible for hosting this session today for Professor Babatunde session, and I'm very glad to welcome once again of our outstanding speaker, Professor Babatunde, whom I believe shall enrich our insight, our knowledge regarding fundamental of dentomaxillofacial radiology or radiography, especially in panoramic radiography interpretation, because as we know, panoramic radiograph is widely used radiograph technique in oral and maxillofacial needs, and I think almost the dentists in the whole world is always use panoramic radiograph to make a proper diagnosis and to make a treatment plan. But Professor Babatunde attend here to improve our knowledge, to improve our interpretation skill about how to be more understand about panoramic interpretation. All right, Professor Babatunde?
That is right.
Okay. Okay, furthermore, Professor Babatunde will deliver his presentation in approximately 30 until 40 minutes, Professor. And the last 20 minutes will be the question and answer session. So for all the participants, if during presentation, if you have any question, you can write down or put your question in the chat box, yeah, in the Zoom chat box feature. Please write your name and your question, and you can also using raise hand tools in Q&A session. Okay, well, for all the participants, for Professor Babatunde, you will have 30 until 40 minutes for presenting your presentation. And well, ladies and gentlemen, please welcome Professor Babatunde. Professor Babatunde, the time is yours.
Okay. Let me set my timer to 40 minutes.
Yeah, you can share your screen.
Okay, I'll do that. How are you?
Okay.
Yeah. Okay, so it's really nice to be here today. Thank you very much.
Yeah, we can see your but still loading, Professor. Okay, we can see now your presentation. Okay, so the time is yours, Professor.
Thank you very much. Thank you, the Dean, Professor Eddie. We are meeting for the first time. Thank you, Vice Rector, Professor Rosling. We have met many times. I spoke at your inaugural lecture when you became Professor. The Dean, Professor Eddie, by the way, one of your staff, Dr. Achin, we were at Okayama together, if you, of course, Achin, then with his children and his wife, you know, we were always riding bicycles all over the town and all that, going to the park to have fun. Thank you, my very good friend, my best friend, Dr. Irfan Sojianto. Irfan was the person that helped me when I first arrived at Okayama. Our Professor Asaomi Sensei gave him the instruction to assist me settle down. Irfan gave me everything that I needed. And I also stayed with Irfan for a couple of days before I left and returned to Nigeria. So I'm very grateful to Irfan. It's a pleasure to be here with the Faculty of Dentistry of Hasanuddin University this afternoon in Indonesia and this early morning in Nigeria. I will try and speak as slowly as possible so that you can understand me very well. I want to stand on all existing protocols, all the principal professors and staff that have been mentioned earlier on. I salute all of you so that I do not need to repeat all the names. So in Nigeria, we usually say we stand on existing protocol. And but I would like to also introduce to you some of the staff of my faculty and university whom I have invited to listen in this lecture and also participate in the signing of the Memorandum of Understanding that will happen soon after the lecture. I have my Deputy Dean, Dr. Adetayo Abore.
Okay, we will wait for Professor Babatunde, maybe any trouble in his country. Okay, for the host, maybe you will, you can,
Can you hear me?
okay,
hear me
Professor, are you there?
You can hear me? I am
Yeah.
here. I am here.
Okay, okay. Okay, Professor, please.
Okay.
Okay.
All right. So I changed the topic a bit to reflect the title of the meeting. So deep understanding of panoramic radiograph interpretation. To have a deep understanding of panoramic radiographs, we need to understand all the lines and patterns that we see on the radiograph. And I'm talking about the anatomy on the pantograph. So that's what we will be looking at today. This is how the radiograph is made. The sensor and the receptor will go in a particular circle around the patient's head to form, like that's how the radiation goes to the sensor.
Excuse me, Professor.
Yes.
We cannot see your screen, your slide presentation.
Okay.
Okay.
I need to reshare.
Thank you. Thank you very much.
Okay. Can you see it now? Can you see it now?
Yes, Professor, we can see your slide presentation.
Okay, so the radiation comes to the sensor and we record the image from one side to the other. We should keep in mind that the mandible is not flat and it's not straight. It is like an arc. It's like a paraboloid shaped anatomy. So the image is made from one end to the other, and you have a flat image of the anatomy of the maxillofacial region represented in this pattern. So we should also know that this is tomography. So there are some structures that would be out of focus, and there are some that will be along the focal trough that will show up on the pantomograph. So this is what the pantomograph looks like. And we now need to understand some of the basics of it. So as it goes from one end to the other, the image is acquired in that pattern, and we have the full image represented on the screen. Now, let's look at the anatomy. The first thing we want to look at is the lateral walls of the nasal fossa. And that is called representing the anatomy of the anatomy of the nasal fossa. We do see that on the pantomograph, and that's the lateral wall of the nasal fossa on the pantomograph. I'm sure that is very clear to all of us. Go back to that to see it one more time. The lateral wall of the nasal fossa as represented in this pattern. Then we also see it here, and that is the lateral wall of the nasal fossa that is represented. Again, we see it here, and that is the lateral wall of the nasal fossa. And one more time, we see it on this image also, the lateral wall of the nasal fossa. Next is the nasal septum that we also can see on the pantomograph, even though it's cartilaginous on the anterior section, but that is bone at the posterior end of it. And that's the nasal septum. So let's see what it looks like on the pantomograph. It's a midline anatomical structure that shows like a radiopacity right in the midline of the pantomograph, and that is the nasal septum. Again, we see it here. That is the nasal septum. Sometimes it's big and sometimes it's not. But when it's big, it has a different name, which I will show in a minute. So like in this case, that is the nasal septum, but you can see that it's kind of enlarged. When it's enlarged in this pattern, we call it septal tubercle or septal tumescence. So that's what you want to call that. That's how to interpret that. Next is the concha. The inferior concha, you have inferior concha, middle, and superior, but we can actually see the inferior concha on the pantomograph. On the anatomy of the skeleton, we can see the red pattern there. On the pantomograph, we describe this as hot dog stuffed in the nose. Hot dog stuffed in the nose is how we describe the inferior concha on the pantomograph. And we see also here the representation of the pantomograph. That is the whole extent of the inferior concha on the pantomograph. Okay. So again, we see here the inferior concha is shown on the pantomograph. Let's move along. That's what it looks like a shell in the nose. That's the inferior concha. And again, we see it right here. It's very well represented on this particular radiograph, pantomograph of the inferior concha. And here's another image that shows the inferior concha within the nasal cavity. Again, we see the inferior concha. This is a very nice pantomograph, by the way. Now we can also see the soft tissue of the nose. On the pantomograph, see the soft tissue of the nose, and that's what it looks like. So soft tissue of the nose, and that's the area of the nose that we are seeing. That's soft tissue of the nose. See the same thing here, and that's the soft tissue of the nose. It's not very well represented on this radiograph, but there we have it, the soft tissue of the nose. Okay. One second. Okay, soft tissue of the nose, one more time. Let's see it here. Okay. So let's look at the maxillary sinus. Maxillary sinus also can be called maxillary antrum, and we also can call it antrum of Highmore. So that's the maxillary sinus on the skeleton, like a pyramid. So we can see that on the pantomograph also very easily. This is probably the first part that students will understand the maxillary antrum on both sides of the jaws. So that's the outline of the maxillary antrum, the lateral wall, the inferior border, and the medial wall of the maxillary antrum. Okay. So that's the maxillary antrum, the lateral wall again, the inferior border, and we'll get to the medial border of that's the medial border of maxillary antrum. So again, that is the maxillary antrum. Maybe this is easier in a pediatric patient. So again, the maxillary antrum. Next, we look at the zygomatic process of the maxilla. The zygomatic process of the maxilla. So that represented on the skeleton is the zygomatic process of the maxilla. That's like the cheekbone. So it can look like a V-shaped entity. It can look like a U. It also can look like a J-shaped entity. So it depends on how the patient is positioned in the machine. Okay, so here it looks like a U. That is the zygomatic process of the maxilla, that line that we are looking at. So it looks like a V here, but it's also the zygomatic process of the maxilla. That's basically the anterior component of the zygomatic complex. So here we're seeing it again. It looks like a J, and that is the zygomatic process of the maxilla. Same thing here. So we'll go posteriorly to the zygomatic arch. And here it is. That is the zygomatic arch. We can see that also on the pantomograph. And those arrows represent the outline of the zygomatic arch. And there you have it, the zygomatic arch. It's very easy to understand because it also links with the head of the condyle. And that's the zygomatic arch, very easily. And you can see the articular eminence here, but that's the zygomatic arch. Again, zygomatic arch. Now, next is the zygomaticotemporal suture, so that you do not interpret this as a fracture line. It's a zygomaticotemporal suture line, and there you have it. That's zygomaticotemporal suture. Again, you see there, zygomaticotemporal suture. Next, we look at the orbital rim. The orbital rim is also represented on the pantomograph, and there we have it. You can see it on the contralateral side also. And again, we have a portion of the orbital rim, that's the inferior component of it. And that's the globe. And that's the inferior component of the orbital rim. Around the orbital rim, the inferior component, we can also see the infraorbital canal for the vascular component of the anatomy, neurovascular component of the anatomy. So infraorbital canal. And this is what it looks like. It should look like two radio opaque lines running through the infraorbital rim. And of course, you know, this is where we'll give anesthesia if there's a patient that has an abscess in the premolar molar region and you still need to give anesthetics. We go on to to block the infraorbital nerve around the infraorbital canal. And that's still the infraorbital foramen. So in this case, it looks curved. So it can, depending on the direction of radiation, it could be curved or straight line. And there we have it again, the infraorbital canal of foramen. Next, we see the pterygopalatine fissure posteriorly. We describe this as a teardrop, reverse teardrop shape. Pterygopalatine fissure between the posterior component of the maxilla and the pterygoid plate. So that's the pterygopalatine fissure. The pterygopalatine fissure becomes important to maxillofacial surgeons when we do maxillectomies and you have copious hemorrhage around that area. That's why you have the venous plexus that is difficult to clip, to arrest, to have hemostasis. So the pterygopalatine fissure one again. Now we also have the pterygoid process of the sphenoid bone. The pterygoid process of the sphenoid bone posterior to the maxilla. And it oftentimes doesn't show so well, but that's what we have, the pterygoid process of the sphenoid bone. The pterygoid process of the sphenoid bone. Okay. Now, this particular anatomy is always very clear on the pantomograph, and it's a landmark for interpretation, and that is the external auditory meatus. So the way to understand, of course, you know this, but for a beginner, the external auditory meatus is always posterior to the condylar head. So when you see the external auditory meatus, you know that it's going to be articular eminence and the head of condyle is just going to be right there. So external auditory meatus, the radiolucent area, circular in outline, bilaterally distal or posterior to the head of condyle, and that's the external auditory meatus. Okay. External auditory meatus again. Then along the same part of the external auditory meatus, we also have the soft tissue of the ear. Soft tissue of the ear is not as radiopaque as bone, but we can make out the outline of the soft tissue of the ear. So that's the soft tissue of the ear in this case. And the same here. Now, next is the mastoid air cells. The mastoid air cells will be posterior to the external auditory meatus. And that's the mastoid air cells over there, mastoid air cells. And now we will look at the styloid process of the temporal bone and the stylohyoid ligament. So we have the styloid process of the temporal bone projecting inferiorly, and attached to that is a stylohyoid ligament. Oftentimes we don't see the ligament if it is not ossified, but if it is ossified, then we can see the pattern or the outline of the stylohyoid ligament. The stylohyoid ligament has 3 different ossification centers, so it does not ossify as a continuum or in a continuous pattern. It ossifies either superiorly, intermediate, or the inferior component. They will not even join completely because they are from different embryological origins. So, and the stylohyoid ligament, of course, attaches superiorly to the styloid process and inferiorly to the lesser horn of the hyoid bone. I often like to talk a lot about the stylohyoid complex, but not because I don't have so much time this morning. This afternoon, I wouldn't talk so much about that. Now, the hyoid bone will also show up on the pantomograph. And it's also very easy to tell the hyoid bone inferior to the lower border of the mandible. That's the hyoid bone. Also, sometimes it could almost lie over the mandible, depending on how the patient the patient's chin is positioned on the machine. And that's the hyoid bone. Again, that is the hyoid bone. Then we can also see the vertebral column. We see a portion of the vertebral column on the pantomograph. We shouldn't see too much of it if the patient is properly positioned. Okay, so that's going to be the vertebral column posteriorly on the lateral component of the posterior to the ramus of the mandible. And also we can see the ghost images of the vertebral column on the midline. We'll talk about ghost images at some point. Then the ramus of the mandible, condyle and coronary processes, those are very easy to understand, interpret on the pantomograph. So that's the ramus, the condylar head, and the coronary process. So we have the ramus here, the head of condyle and the neck, and the coronary process of the mandible. The mandible is easier to interpret than the maxilla because there are not many lines on the mandible like the maxilla. So the ramus of the mandible, condylar head and neck, and coronary process. And we see the same thing here, the ramus of the mandible, the condyle, and the coronary process. Then we look at the inferior alveolar canal. That will show very nicely, particularly the inferior boundary of the inferior alveolar canal. The superior boundary does not show completely as it moves towards the midline. So that's the inferior alveolar canal. And that's also the inferior alveolar canal here. Inferior alveolar canal. Now also we look at the mental foramen. So the inferior alveolar canal continues anteriorly and exits around the roots of the premolars as the mental foramen, where the mental nerve comes through. And you see it as a radiolucent area around the apices of the mandibular premolars. So the mental foramen. Again, mental foramen in an edentulous patient. So for the edentulous patient, you actually can see the mental foramen almost at the crest of the residual bone. Then we can also see the floor of the nose on the pantomograph. That's the floor of the nose. That's the palate, but the floor of the nose is going to be superior to that. Okay. So floor of the nose and palate would almost look together the same, but that's the hard palate there. And now the hard palate goes on to the soft palate posteriorly, and that's the soft palate. So again, this is the hard palate, and that is the soft palate. So soft palate will lie on the tongue posteriorly and into the airway. So again, you see let's see the soft palate here. And that's the soft palate also. Soft tissue of the tongue is also some anatomy that we need to interpret on the pantomograph. And it always depends on how the patient is positioned and the instruction that is given to the patient. The basic instruction for patients is that they should put their tongue against the roof of the mouth, which is the palate. And when you do that, you will see the tongue lying against the hard palate. And that's the outline of the soft tissue of the tongue. So that's the tongue that we're looking at. It looks so huge, but it's lying against the hard palate and against the soft palate in this case. Again, that is the soft tissue of the tongue. This particular patient did not put the tongue completely against the roof of the mouth. So you can see the radiolucent line between the So between the soft tissue of the tongue and the hard palate. For this is not good for interpretation, but however, that is the soft tissue of the tongue. So the same thing here, that's the soft tissue of the tongue. We can also see adenoidal hyperplasia. We don't use this radiograph for adenoidal hyperplasia interpretation. If we have to use images, we use lateral ceph to interpret adenoidal hyperplasia, but we can still make out the adenoids posterior to the airway. Those are the adenoids. There's a mental triangle area that oftentimes will show in a different pattern on the radiograph, depending on how anteriorly or posteriorly the patient is positioned on the pantomograph. And because of this, oftentimes we're not able to use the pantomograph to really interpret the anterior the mandibular teeth very easily. So that's a mental triangle. All right, so there are components of the X-ray unit that we should look at that can also show on the radiograph. There is a headrest and a chin rest that can show up. So that is the bite block that the patient is biting on between the maxillary and mandibular anterior teeth. It often shows on the pantomograph. Same thing is shown here. So that is the headrest, that the holder, the component that holds through the patient's air and head. So the components of the machine that will show. Then we have ghost images. So regarding ghost images, what happens is, if you look at the shape of the mandible, for instance, when you image one part of the mandible, say for instance the left, the right side of the mandible will be out of focus. Out of focus meaning it is out of the focal trough. And when it is out of focus, it could show up on the pantomograph as being out of focus because it is not part of the tomogram. And it becomes a ghost image if it shows up. So let's look at this, for instance. So this will be the ghost image. This is the right mandible, and that's the ghost image of the right. And this is left mandible, and this is the ghost image of the left, because they're out of focus. Out of focus and out of the focal trough. So that's ghost image there, and that's another ghost image. Okay. So this is the ghost image of the left ramus condyle region of the mandible. So this is ghost image again. I just showed you. So you can see the shape, and that's the shape of the lower border of the mandible, angle of the mandible ramus, and same thing is shown here. So ghost images. So that's a ghost image of the contralateral side. And so ghost image again, ghost image for the hyoid bone. Ghost image again. So the ideal position for the patient on the pantomograph, now again, we're talking about focal trough, that every portion of the mandible of the jaws should be within the focal trough, and any particular anatomy that is out of focal trough will not be clearly represented on the image. So that's the midline that represents the vertebral column. So this is the representation as we make the image. So there is a focal trough through which radiation goes, and anything outside the focal trough will not be represented. So everything along this particular pattern of the mandible is within the focal trough. So you have that, and you make your exposure, and it goes through, and you can see the anatomy is being represented on the sensor or the receptor. So in this case, this particular anatomy is out of the focal trough, and you can see that the image looks larger and this is some form of the ghost image that we looked at. This particular image will not be good for interpretation, whereas the other pattern where the image, the circular entity that looks pink, that is within the focal trough, is represented almost as the same dimension as the original on the receptor. So that is because this is within the focal trough. When you move it out of the focal trough, like in this case, the resultant image will be magnified. Like you have here, to be magnified and distorted. You can see a circular image that has taken a different shape altogether. And that's what, and this also explains the focal ghost image that I was talking about earlier on. And here also it's out of the focal trough, and it's also be represented in a different way. You can see it's also distorted. Okay. So ideally, patients should be positioned within the focal trough, such that the anterior teeth are within the focal trough in this case, and images are not like this. This is out of focal, not posteriorly, not even in this pattern. So, and that would, the way you position the patient would affect the resultant image, okay, particularly the anterior component. You can see anteriorly here, we cannot make interpretations for the images that are here. So patient's rotation, the midline should be directly at the center. There are lights on the machine that will tell you whether you are right on, like in this case, the patient is off-centered and it doesn't look good because there is no symmetry of the, you can see also here, there is no symmetry. So if you position the patient too far anteriorly or too far backwards, it will also affect the way the anterior teeth are represented. So now these anterior teeth are out of focus because they're not within the focal trough. If you put the patient too far backwards, it will also affect, to also take the anatomy out of the focal trough. Okay. And if you position the patient's chin too far down, you see now that you have lots of the vertebral column showing, and the mandible and the maxilla are squashed into the image. So this is not a well-positioned patient on the pantomogram. Sorry, I'm rushing a bit because I have just about 6 minutes left. So when you position the patient wrongly, it will affect your ability to interpret. And it is the responsibility of the doctor to direct the assistants in the clinics to make proper interpretation. So we could have pseudo fracture or distorted anatomy due to movement. So if the patient moves, you may have step deformity of this pattern and you will think it's a fracture, but it is actually due to movement of the patient. Okay. So that's what we have there too. Okay, so that, I'm putting this particular case so that we can have some varieties. So this was a case from Okayama University where we saw a patient, a 77-year-old male that, so this is the history, let's even say 85-year-old male that had, came to the clinic, had a complaint of drainage from the chin and the right lower mandible. The patient was on this particular medication, particularly for osteoporosis. So the key thing is when you see indication that patient is on medication for osteoporosis and patient has jaw lesions, abscesses in the jaws that are not healing, initially you suspect osteomyelitis, and rightly so. So when you look at this and you want to interpret, okay, let me take it step by step. So when you look at this pantomograph and you want to give interpretation, the way we do it is, as dentists, you want to identify the teeth present. In identifying the teeth present, you want to name and identify each tooth present on the jaws. So maxillary right, second molar, first molar, maxillary right, second premolar, first premolar, canine, lateral incisor, central incisor, maxillary left, central incisor, lateral incisor, canine, first premolar, second premolar. That's how we do it. Then you come to the mandible. Mandibular left, third molar, first molar. Maybe this is second molar, first molar. Then lateral, canine, lateral incisor, central incisor, and you move to the contralateral side. Mandibular left, lateral central incisor, canine, lateral incisor, premolar. Then there is a tooth here, which looks like the second molar. So you need to identify the teeth present carefully. Then you take a crossly look from the right to the left in the maxilla. You look at the maxillary sinuses. Do you see anything? The outline of the inferior border of maxillary sinus is very nicely shown here. You can see the orbit, and you can see the nasal fossa. Then you do the other side. There is no radiopacity, there are no lesions within the maxillary sinuses. Then you come down to the mandible. Look at the condyle, the coronal processes, the ramus of the mandible looks good. The inferior border, the alveolus, they look okay here. But when you come to the contralateral side, you can see that this does not look as you expected. This is not normal when compared to the contralateral side. So here you have mixed radiopaque radiolucent lesion, looks like wool pattern appearance. Obviously, you can still make out the outline of the inferior alveolar canal, though, and that looks to be radiolucent margin that looks jagged and just runs around like that. So it looks somewhat like this is bone that is being destroyed, and it has it's being what you call sequestration. It's being sequestrated by these radiolucent lines that run around it. And if you look at this very closely and match what you are looking at with the history, you remember that this said the patient was having drainage from the chin. So this looks like an abscess, some form of infection. And you start thinking, well, maybe this is osteomyelitis, but is it chronic or is it acute? With a long history that the patient is presenting with, is obviously not acute. So it looks like chronic osteomyelitis. The chronic osteomyelitis will be one of the differentials for this case to start with, given the history of the abscess of drainage. However, when you now look at, so that's the pantograph, you also have the APIS call that does not show much, except it shows the soft tissue swelling around the chin there. When you look at the history and you're looking at the medication for osteoporosis, that changes your differentials and your thinking. Now, this may be medication related. And this image was taken after the total, we call it total clearance. All the teeth had been removed, all the standing teeth that we had on the original radiograph were removed in this case, and this is called total clearance. So the diagnosis was medication-related osteonecrosis of the jaw, and it has these clinical features where you have areas of exposed bone after dental treatment. Is usually the key to the diagnosis, and it affects the posterior regions of the maxilla and the mandible. When you look at the images, particularly in this case, pantomograph, you'll see a sequestral, like we saw here. So this is, I was describing that to you earlier on. So you see the sequestrum, you can see the recent line separating this bone and keeping it away from the main body of the mandible. So that becomes a sequestrum. So in M. Ronge, you'll see the sequestrum, and you start thinking osteoregional necrosis of chronic osteomyelitis. Osteoregional necrosis would not be important if the patient has had radiation therapy. Then osteoregional necrosis becomes another differential. However, with medication for osteoporosis, you want to start thinking of medication-related osteonecrosis. My time is up, and it has staging. This last case is just to show us the odontoma around. Again, you want to identify all the teeth present. When you identify all the teeth present, then your eye will go to the fact that this maxillary molar is not along the line of dentition and is pushed superiorly into the antrum, and there is a big radiopaque mass that is preventing its eruption. So you start wondering, what might this be? So there is a way you look at the outline of that. Does it have like a PDL space around it? And it may just be odontoma, which could be complex or compound. But in this case, this is complex odontoma. Okay, so I'm sure there are familiar faces here. Here is Irfan, my good friend. And that's Achin. And these are the professors. I don't remember her name. I don't remember his name. But this was one of the final year students when I took this picture. This was taken at Kurashiki. I'm sure Irfan will remember. Of course, here we were having fun at the Kurashiki tourism center with Irfan, Achin, and I think he was a student. These two guys were students at that time when they came to Okayama for the program. So thank you very much. I'll stop here.
Sorry, please, host.
Can you hear me? Can you hear me? Can you hear me?
I think it's very fundamental, Professor, because you talk about the anatomy of radiological in panoramic radiograph, and after that you give us the example of your case, how we assess the abnormalities of the panoramic radiograph. Maybe I have some curiosity, Professor.
Okay.
The first is, I would like to ask you about how do you think about the anterior area of the mandible and of the maxilla, because some of literature said they don't recommend to us to assess abnormalities of the anterior area of the maxilla and the mandible, because there are so many superimposition in there. How do you think about that?
Yes, that is correct. And like I mentioned, in the anterior region, oftentimes you have the vertebral column superimposing along the midline on the pantomograph. So you are not able to make adequate interpretation of anatomy on the maxilla, on the mandible anterior region. Also, if the patient is not properly positioned on the machine and the chin is too far forward or too far posteriorly, the teeth of maxillary and mandibular teeth will not show clearly on the image, and you will therefore not be able to make interpretation. So it is correct. So what we do therefore is, when you make the pantomograph, but you need to specifically look at the anterior region, you can just include with that the periapical radiographs to enable you to see the area very well.
Okay, so maybe we have to more experience, yeah, to how to see the abnormalities of the panoramic radiograph. And also interesting, like you said before, that some of anatomical landmark that I think so far I cannot recognize in the panoramic radiograph. Like you show us how to recognize the soft palate in the panoramic radiograph, or the zygomatic temporal suture. Yeah, I think it's very interesting that there are so many anatomy we can see in the panoramic radiograph. Of course, for a high quality radiograph, Professor. Yeah.
Well, so yes, that is correct. Every line on the pantomograph has interpretation because it represents anatomy. And for us to have deep understanding of radiographic interpretation on the pantomograph, we need to know what is normal to start with. And what is normal will be all the lines. So zygomatic-temporal suture line is part of it. And if you did not know that this was normal anatomy, it's not unlikely you might think it's a fracture line.
Okay. Thank you very much, Professor, for your very insightful lecture to us. For your information, now in Indonesia, we have 4 residency program, or I mean, oral and maxillofacial radiology specialist program to train the dentists to be an oral and maxillofacial radiologist. In Indonesia, we have 4 program now. In the University of Hasanuddin University as the 3rd, and before we have Universitas Pajajaran in Bandung, we have Universitas Indonesia in Jakarta, and the latest in the Surabaya Universitas Airlangga. So I think your insightful lecture today will make us have many more experience to see the panoramic in the right way. Okay, I see one participant want to ask you maybe a question for Dr. Fadila. Yeah, okay, you can unmute your Zoom and deliver your question for Professor Babatunde.
Sorry. Thank you for the chance. Maybe say in the morning for in Nigeria. Thank you very much, Professor Babatunde. Let me introduce myself first. My name is Siti Fadila Umar Mataliti. I am I'm a student of oral maxillofacial radiology special program, and still in the 2nd semester. So I have to ask you something about panoramic. My question is, Professor, can you explain me the simple instruction to the patient who wants to make a panoramic photo to put the tongue at the exactly position on the palate, of course, to avoid the palatoglossal airspace. Is the tip of the tongue or the body of the tongue should be put on the palate? I think that's all about my question. Thank you very much for the chance. Thank you, Professor.
Okay, Professor, you can directly answer the question.
Okay. So Fadila, thank you for the question. I think it's very simple. You just need to tell the patient, take a deep breath, swallow, and as a swallow, the tongue assumes a natural position when you swallow, and keep your tongue right there. And that's how to get the patient to lock into that particular position. If you say put the tip of the tongue on the palate, then you will get the wrong position. So you just tell the patient, swallow your saliva. And once they do that, say, just rest your tongue on the palate and it gets into the right position. I'm sure that's clear, right? Fadila?
Oh, okay, thank you, sir. So just make sure. So we have only to ask the patient for swallow and not to put the tongue to the palate. Is it right, Professor?
So yeah, well, the instruction is put your tongue to the palate. However, in order to get the patient to get into that position, when you even if you swallow now, you see your tongue immediately goes to the palate. Swallow your saliva, and that's where you want the tongue to be. It just stays on that palate and keep your tongue to the palate, and that is it. The swallow your saliva helps the patient to execute your instruction to put the tongue to the roof of the palate. Exactly. They go together. Fadila?
Okay, thank you very much for your explanation. Thank you, Professor, and thank you for the chance.
Okay, thank you, Dr. Fadila. Very interesting, Professor, because some the almost problems in the panoramic radiograph when we take panoramic radiograph is the artifact in the maxilla, the anterior region of the maxilla superimposition with airway space, and the usual instruction to the patient, we always tell to the patient to put their tongue in the hard palate, but you suggest us to, it's very simple. Just tell the patient, please swallow your saliva, and directly the tip of our tongue is come to the hard palate. I think like that, Professor.
Thank you.
Yeah. Okay. Maybe any question for the participant? You can use the raise hand feature to directly deliver the question for Professor Babatunde for his presentation about deep understanding of panoramic interpretation. Maybe the key, the key for how to be more understanding for panoramic radiograph interpretation is a good knowledge for anatomy, Professor, because if we have a good knowledge in recognize the anatomical landmark in the panoramic radiograph, we can distinguish the abnormalities from the
that is
normal. Yeah. Okay.
Maybe
maybe any suggestion, Professor, about how to be more understand, to be more can be more analyze the radiograph panoramic, maybe because like I said before that panoramic radiograph is widely used in the world, in Indonesia panoramic radiograph is very common radiograph technique, but some of them is have a low diagnostic value because some of them is take panoramic radiograph but is not indication for panoramic radiograph. Maybe you can give us some suggestion what the main indication of panoramic radiograph for make a good diagnosis or treatment plan.
Okay, so the indications for panoramic radiograph is basically diagnostic. At my center in Nigeria, what we do is every patient that comes into the diagnosis clinic, every new patient that comes, we have a pantomograph, a panoramic radiograph we make for them, because the panoramic radiograph gives an overview of the entire jaws. So you do not need to make multiple radiographs. By the way, panoramic radiograph is one option. There is an alternative to panoramic radiograph, and I'm not sure if you guys practice that in Indonesia, and that is complete mouth series. Complete mouth series or full mouth series. When you say complete mouth series, it means you are taking periapical radiographs of all the standing teeth, and you also include 4 bite wings. So you are taking periapical radiographs for the molars, for the premolars, for the canine, the lateral incisor, central incisor, maxillary, and same for the mandible. Then you're taking bite wing radiographs for the molars and premolars on both sides. Usually altogether, the complete mouth series comes to 20 radiographs. So if you have the complete mouth series, what you are looking at on the pantomograph in terms of dentition, you can also see on all those radiographs. However, the pantomograph gives you additional anatomy or anatomical region to look at. The entire mandible, including the coronary processes, the condyles, the inferior border of the mandible can be seen on the pantomograph. You can look at the maxillary sinuses, on the pantomograph, you can see some component of the nasal aperture and the floor of the orbit on the pantomograph. So you have a lot more anatomy to see on the pantomograph. So the major indication will be as an overview for comprehensive examination of patients, and it is an alternative to complete mouse series. Now, if you take it a bit towards radiation physics and radiation protection, you actually expose the patients to less radiation with pantomograph than complete mouth series. Also, on the clinical setting, you only choose between pantomograph and complete mouth series. You don't use both. However, from what we have discussed so far, when you make a pantomograph and the anterior region not so clear, then you can have two periodical radiographs also to reflect the anterior teeth, so you can look at the anatomy of the anterior teeth very well. So the pantomograph is basically for overview of lesions of the maxillofacial region, and that is what it's also baseline. However, in undergraduate training, pantomograph is important. But as the world changes, you mentioned cone beam CT at your end, three-dimensional imaging would give you better analysis, better insight into the lesion, so you can look at the different multiplanar views of the lesion and be able to make better interpretation. And I also mentioned earlier on that when you want to interpret the pantomograph, it's always important to understand the anatomy, which was why I thought the way to approach this lecture was to teach you to present the anatomy. If we looked at the pathology is not good. Pathology would take from the knowledge of anatomy, because if you do not know what is normal, you may not know how to appreciate what is not normal. So pathology would come as you practice and as you learn in the programs, but anatomy is fundamental to understanding what you expect to see, so that when you do not see the periodontal ligament space, you know that, oh, something is going on here. Why am I not seeing the PDL space? But when you see a lesion and you have the history like I did present, you see a tooth that is not erupting, and you see a mass of a radiopaque mass preventing that tooth from erupting, you begin to ask yourself, what is going on? And with the knowledge of pathology, you can make an interpretation. But with knowledge of anatomy, you can know that, oh, this is not right and this is right. So those are the indications and also the way to interpret the pantomograph. But it's not, if you want to do third molar surgery, for instance, pantomograph is good because it shows you the third molars, it shows you the entire region and the adjoining bone. Whereas if you want to look at the periodontal ligament space and look at lesions, interproximal caries, pantomograph may not show that very well, especially if you have overlap of the adjoining teeth. Right. So in that case, you want to do bite-wing radiographs for interproximal caries. So I say that again, for interproximal caries, the appropriate image is bite-wing radiographs, because that separates the teeth. The contact areas are separated, and you can see incipient caries very clearly on the pantomograph, on the bite-wing radiograph.
Yeah. Okay. Okay. Very interesting, Professor. Because you said before, in Nigeria, all of the new patient come to your dental hospital, take a panoramic radiograph for any condition. Yeah. Correct. Okay, so maybe it can be you like you said before, like baseline data. I think it's very useful also for antemortem data, yeah, Professor, because some of the disaster victim in Indonesia, we meet any difficulties to get the antemortem radiograph. But in your country, panoramic radiograph like oral screener, oral screening for general evaluation of oral and maxillofacial area, like that, Professor.
That is correct. Forensic science, forensic dentistry. It's useful. In the US, that's also what happens, because pantomograph is baseline. So when you have disaster victims, for instance, they recruit all the dentists to supply their images to interpret, because the jaws will not disintegrate during disaster. So you can use the anatomy of the jaws on the antemortem image, like you mentioned, to identify victims. Same as prostheses that are inserted into patients, maybe hip replacement, knee replacement, they have signature. So during disaster, those prostheses are also exhumed and used by way of the signature to trace which surgeon or which clinic inserted the implant. And they use that to identify the victim. So yes, forensic dentistry uses the pantomograph. Thank you.
Okay, thank you very much, Professor. It's very insightful. Thank you very much. We hope if now we meet in the virtual room, we hope in the next time we can meet directly in Indonesia. You come to our country, you come to our university to deliver the other lecture for us, because I think it's very fundamental for us to how to more understand for panoramic radiograph interpretation, because like as we know, panoramic radiograph is very widely used. Almost all of the dentists in the world use the radiograph panoramic as oral screening, as how to make a diagnosis and a treatment plan from a radiograph. Okay, I think no more question for this session. I'm very glad to have Professor Babatunde for this special session today. And thank you very much, Professor. In between your busy day, you spare your time with us to deliver your fundamental presentation, insightful presentation. Thank you very much. And maybe before closing, we have any certificate from the committee. So I return back to the Master of Ceremony. Thank you very much for your amazing presentation, Professor Babatunde. We hope everything fine in there and in here also. Thank you very much, and good morning.
Thank you.
Okay. Thank you, Prof.
Thank you, Doc. What an amazing lecture, Professor. The lecture so useful for us. And the next session is, I would like to welcome the Dean of Dentistry Faculty of Hasanuddin University to deliver the certificate to Professor Babatunde.
Okay, thank you. Professor Babatunde, thank you very much for your kind support to our institution. This is a certificate for you from the organizing committee. Thank you very much.
Thank you. Thank you.
And the next is presenting the certificate of appreciation to the moderator. And I would like to welcome the head of oral and maxillofacial radiology specialist program to present the certificate to the moderator.
Okay, I give you certificate. Dr. Ulil, very amazing and moderator. Yes, and thank you very much for your.
Thank you, Prof.
Moderator. This is your certificate.
Thank you very much, Professor Baruna, as our head of Oral and Maxillofacial Radiology Specialist Program. Prof. Baruna is head of Oral and Maxillofacial Radiology Specialist Program in here, Professor Babatunde. Thank you.
Okay,
Thank
ladies
you
and
very much,
gentlemen.
Professor Babatunde.
Okay, well, ladies
Thank
and
you very much.
gentlemen.
Thank you.
Yes. Thank you, Professor. Now we are in the last session. To all the participants, please turn on the camera for taking picture together with Professor Babatunde. So please, to the participants, open the camera, please, and we can take a picture together. Please, host, take a picture. Page 1, 1, 2, 3. Okay. The next page. 1, 2, 3. Well, the next page. 1, 2, 3. Well, the next page. 1, 2, 3. And the last page. 1, 2, 3. Okay, thank you for all the participants. As the master of ceremony, thanks to Professor Babatunde to spare your time being a speaker in this guest lecture. On behalf of thank you so much for all the participants. Thank you for the attention and see you on the next event. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Prof. Hana, Prof. Harjo, Dr. Umi, Dr. Haris sudah bersedia join pada webinar hybrid pada hari ini.
Thank you very much for all the participants. Terima kasih Prof. Dok sekalian atas partisipasinya. Rekan-rekan dari PPDGS Radiologi Kedokteran Gigi Unpad, UI, dan juga Unair, terima kasih banyak. Semoga radiologi kedokteran gigi Indonesia semakin maju. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.